In this video, I'll be answering viewers' questions on Lemtrada, one of the most effective and the most complicated MS-DMTs on the market. If you'd like to better understand Lemtrada, don't turn away, because that starts right now. Howdy! Thanks for learning about MS with me, Boster. I started this YouTube channel to help my own MS clinic patients learn between visits, and it's my hope that through these videos, I can help you learn too. I love viewers' questions, and in this video, I'll be answering targeted questions about Lemtrada, or Alemtuzumab, one of the most complicated and the most effective DMTs I've ever used. So let's jump in. Josette asks, "Hi sir, what about Lemtrada versus Ocrevus?" And this is a fantastic question. In my opinion, Lemtrada and Ocrevus are amongst the two most effective medicines currently available to treat MS. And I think the decision between going with one versus the other is based on a philosophical answer. Yes, we could talk about the efficacy data points. Yes, we could talk about the particulars of the side effect profile. But in talking to hundreds upon hundreds of families about this exact question, I think we in fact make the decision using a philosophical answer. Let me explain. Ocrevus is a medicine that's continuous. You take it twice a year forever. It's highly effective in suppressing MS. It also has a relatively reasonable side effect profile. Lemtrada is rather different. It's not a continuous medicine. It's induction therapy. You take the medicine for several days up front, then you wait a year, you take a couple more days, and then there's about a 50% chance that you'll never be retreated. When someone is considering Ocrevus or Lemtrada, they're really considering how they want to approach their MS, how they want their MS to be treated. Some people are willing to accept significant upfront risk and complexity with Lemtrada in exchange for the potential of having quiet disease for years to come. Many people, however, are not okay with that, and they are not willing to accept significant upfront risk and complexity, and it's much more comfortable for them to start on Ocrevus. I don't think that there's a right answer and a wrong answer, but when I think about it in these two avenues, there isn't any between ground. People gravitate towards, let's do Lemtrada, let's accept upfront risk, let's accept upfront complexity, and I want the chance of having quiet disease in the absence of retreatment. Or they say, I'm not comfortable doing that, and I would rather be continually treated with a highly effective medicine that will suppress my disease. I would love to hear if you agree with my analysis, and if you also agree that this is a philosophical decision. Please leave your comments and your answer to this question down in the section below. Annie Griffin writes in, "Hi, I'm on Campath, which is Lemtrada, and this drug has been put on a watch list in Ireland. I was the first to be put on it in Cork, and it's given me a new lease on life. Is it the same over there?" Annie, this is a really great question, and let me start by thanking you for sharing your situation. As I mentioned in the last question, Lemtrada, Campath, is a highly effective medicine, and I can share example after example of really exciting outcomes that people with MS have experienced when taking the drug, similar to what you're sharing here with a new lease on life. But we absolutely must remember the risk-benefit relationship. And Lemtrada is very complex. There's a lot of baggage, if you will. And in the European Union right now, they're in the process of reviewing the safety profile of Lemtrada, hence the reason it's been put on a watch list. It's being scrutinized, and there's nothing wrong with that. When someone signs up for Lemtrada, they have to accept 4 categories of risk. There's a very high likelihood of infusion reactions, so their body may react poorly while they're receiving the medicine. Now, that can be mitigated by proper infusion medicine, but I'm not trying to make light of it. And in fact, there's been some scary outcomes, and so I don't want to sweep that concept under the table. The second is a risk of infection, and this medication temporarily lowers the immune response, subjecting the person to potential risk of infections. Once again, there's ways of mitigating that risk, for example, placing people on antivirals like acyclovir, but that risk is still there. The third category of risk is causing autoimmunity. The way this medication works can increase the risk of developing other autoimmune conditions. And I have lots of videos on this channel where I talk about that. I'll throw links up above so that you can watch some of those videos if you're interested. But very briefly, when you take Lemtrada, there's a risk of having autoimmune thyroid disease, autoimmune blood condition called ITP, autoimmune kidney disease, and to a much lesser extent, autoimmune liver disease. All the things I just listed are treatable, and there's programs in place to catch them and monitor them and manage them, but they're still present. Lemtrada has a very low risk of cancer, but the risk is still there. And so, obviously, this is a medication that we can't think about lightly. It's one of my absolute favorites in a family that is willing to accept the risk. So how do we grapple with all this? Not just for the European Union, but just for people with MS or people impacted by MS that are considering this highly, highly effective therapy. I think we have to, A, consider the risk of the disease. Untreated MS scares me much, much more than the side effect profile of this drug. Undertreated MS scares me much, much more than the side effect profile of this drug. And I think that one of the things that MS clinicians must do is accurately describe the risks of untreated or undertreated MS. It's only then that we can really consider the risk-benefit of a medicine. Once we have a good or a proper understanding of what it means to have undertreated MS, now we turn our attention to the specifics of the risk and the benefit of this medication. And we have to be very honest and open about all the benefits and all the risks. And we have to place those risk benefits inside the context of this disease. In having this conversation with hundreds of families, sometimes I get scared looks like this and they say, no, no, no. And that's okay. I certainly do not want to suggest that someone who's uncomfortable take this medicine. But sometimes I get, tell me more. And really, there isn't a right or a wrong answer. Annie, I am delighted this medication is working for you. I have had tremendous success using it with many, many of my patients. But I imagine that you have properly thought through the medical risk benefit, and I am guessing that you are amongst the people that are willing to accept upfront risk and upfront complexity in exchange for, as you put it, a new lease on life. Thank you for watching the channel, and thank you for asking a provocative question. And now for coffee. Kate McGinley writes in, question, would you ever give Lemtrada as a first-line treatment? Thank you from Wales. Well, hello, Kate, and thank you for writing in. My answer is, heck yeah, I would. Lemtrada is induction therapy. It's intended to reboot the immune response and reset the trajectory of the disease process. The data is very clear. The earlier that we use Lemtrada, the better it does for the individual long term. Here in the United States, the American label for Lemtrada places it not first line, as we're talking about, and not second line, like in Canada, but third line, which hurts my heart. The reason the American FDA has done this is because of safety concerns. And unfortunately, placing this medicine third line means that we're using it farther down the line in someone's disease process, after they've broken through one and then two drugs. If we were able to use the drug earlier, it would have a more impactful result. And I can share with you anecdotally that there's been a couple unique cases where people presented with extremely severe MS. We were able to work closely with the insurance payer who understood the concern and need, and we were in fact able to use the drug up front much, much earlier, and in fact first line. And I can say anecdotally, it's the way to go. Thank you for asking the question, Kate, and thank you for watching the channel. MJ writes, coming up on 5 years after Lemtrada. Wait for an attack or start another therapy? I know that some have gone 7 years post-treatment, but I feel like a time bomb. MJ, thank you for writing in. Excellent question. Most drugs that human beings take are continuous. They're taken on a continual basis forever. For example, I'm on a cholesterol pill. I take it every morning. Lemtrada is rather unique in that it's not a continuous therapy. It's discontinuous. It's induction therapy. You take 5 days in a row, wait a year, take 3 days, and then we never redose you unless you have a new clinical attack or 2 new spots on the MRI. Going out 8 years, 50% of human beings have never been redosed because they've never had an attack and they've never had new spots on the MRI, which is amazing. But conceptually, it's very, very different. What I want to convey to you, MJ, is that what Lemtrada is doing is it's not trying to temporarily suppress your immune response. It's not trying to block your immune response. It has rebooted your immune response. It's changed it so that it now behaves differently, which I think is really refreshing. This is an important conversation to have with your provider. And if you've gone 5 years and you haven't had an attack and you haven't had new spots on your MRI, I would submit to you that we can use the term remission. It doesn't mean you're cured, but it means that you've gone 5 years with no discernible disease activity in the absence of treatment, which is freaking amazing. If you are clinically stable, one might decide to keep on monitoring you. And in my clinic, that would involve coming in for clinical visits where we can take careful history to make sure that you're not slipping through the litmus test of life, doing examination testing to make sure that we're not picking up new subtle problems on neurological examination, and getting at least annual brain MRIs to make sure that we're not noticing new spots. If all of those things are met, it would be reasonable, in my opinion, to keep on keeping on. But again, you have to talk to your provider for the right decision for you. Thank you for the channel watching. Thank you for watching the channel, and thank you for the awesome question. If you'd like to learn more about Lemtrada, please check out this Lemtrada playlist right there. YouTube Analytics thinks that you would love this video right there. And if you haven't yet subscribed to my channel, please consider doing so. Just click the little circle with my face. Go ahead, click my face. My name's Boster, and thank you for learning about MS with me. Until my next video or my next live stream, take care.